Welcome to the Bassler Center for BRCA's annual Breakthrough and Discoveries panel. So I am Susan Domchek. I'm the Executive Director of the Bassler Center. I'm going to be the moderator for tonight's discussion. And we are grateful to be joined this evening by an incredible community of patients, care providers, advocates, mutation carriers, family supporters, both here, but especially online. Again, about 250 people joining virtually from across the country. The virtual stuff is a real bonus for us. Today, in addition to having this room, we had basically about 450 to 500 people online the whole day. So it really is able to allows us to expand our reach. Yeah, just in case you're wondering. So this conversation tonight is really going to be shaped by you, our community. This is for you. It's reflecting your strength, insight, and a really shared commitment by everyone to this cause. So what we're going to do is start with a question and answer focused on where we are today in BRCA-related research and care, and then transition to a conversation more about where we want to go from here. We took a lot of questions in advance, so I've tried to kind of summarize a lot of themes. We won't be able to do things live, but as always, you can reach out to us for other questions. So right now I'm going to introduce our panel of experts. So Dr. Ephrat Levy-Lahad is the founder and Robert Chimers Newstein, director of the Fold Family Medical Genetics Institute at Share Zedek Medical Center. I must have mispronounced 4 things in there. And a professor of internal medicine and medical genetics at Hebrew University of Jerusalem. And Dr. Levy-Lahad is this year's Global Prize recipient, honoring her work leading population-based BRCA screening programs, among other things. Dr. Alan D'Andrea is a Fuller American Cancer Society professor of radiation oncology at Harvard Medical School, the director of the Center for DNA Damage and Repair, and the director of the Susan F. Smith Center for Women's Cancers at Dana-Farber Cancer Institute. Dr. D'Andrea is the recipient of this year's BRCA Impact Award, honoring his work unraveling the Fanconi anemia BRCA pathway, which contributed significantly to the development of anti-cancer drugs such as PARP inhibitors, and something that we'll be talking about during the panel. So we're going to start with some sort of basic questions about BRCA. And to summarize the first bunch of questions, I could summarize it as, individualized risk. I think that, people get these reports, and whether it's BRCA1 or BRCA2, it says 70% lifetime risk of cancer. And I was just wondering if you could sort of comment on BRCA1 and 2, alike or different, and cancer risks. Does it matter what kind of mutation you have within these genes?
So the gene does matter, and we know that BRCA1 is generally associated with higher risks, particularly for ovarian cancer, but also for breast cancer, and that is compared to BRCA2. Now, within these genes, there are differences between the specific types of mutations. I would say they're existing. Do not necessarily have huge effects. And just as a general comment, I always wonder whether, as scientists, we're really interested in the specific risk of a specific variant. I'm not sure it makes that much difference to our patients. Does it really matter if your risk is 60% for breast cancer or 70% for breast cancer? Does that really make a difference in your decision making? And I think that's actually one interesting thing to study, is to understand what is meaningful to our patients in terms of the risk assessment. So while we try to get to this maximal precision, maybe that's not what matters the most to our patients.
Especially when precision is a little bit of an illusion. We generally give ranges of risk, and for any individual patient, the answer is, if you will, 0 or 100. It either happens to you or it doesn't happen to you. And I see Jada Hamilton in the audience, and we've been trying to do work on polygenic risk scores to pull in to BRCA carriers, and what Jada has found is that it decreases, if you will, decisional conflict. But from the standpoint of, if you will, physician, it doesn't necessarily track with the decisions, if this makes sense. The people that you might think are the highest risk are not all the ones that have mastectomy, and the ones at the lower risk, not all the ones who screen. So individually, people take this information in and use it in different ways. So your point is well taken. But I guess a question for you, Alan, is, okay, well, could the different in mutations and mutation-specific risks tell us something about biology? Because we do know that mutations in different part of the gene,
right,
might matter.
Yeah. No, as a scientist, we care a lot about where the mutation is. So if a BRCA1 gene encodes a BRCA1 protein, and that protein has a particular mutation somewhere in the protein, we then could show differences, big differences, between how that mutant protein interacts with BRCA2, BRCA2, I should say, or how it interacts with other proteins in DNA repair. But you're right, from the point of view of patient care, what do we care as much about the variability of the mutant protein? Probably not.
I mean, I think the question is, in the future, if we understood those things, maybe we could figure out how to intervene a little better, depending on the different mutation type. But right now, clinically, it hasn't been particularly actionable yet.
Right.
So I think another kind of basic question was just, when should people be tested for a known mutation in the family? And one question was specifically about men. So again, we generally in the United States test women at 25, because that's when we start breast MRI screening. And that's for BRCA1 or BRCA2. I'll be interested if Israel does that a little differently, because other countries do it a little differently. And for men and for women, for men, we talk about instituting some screening at 40 for things like prostate cancer screening. But we also talk about testing for reproductive planning purposes. And so one thing which I'll reflect back to Alan in a minute is Fanconi anemia, where you can have 2 bad copies of particularly BRCA2, which can lead to a bad childhood disorder. So knowing this information can impact that decision making, and also the ability to do pre-implantation genetic testing. So going through in vitro fertilization, screening the embryos, only reimplanting the embryos without the gene mutation, which is an option rather than any kind of requirement. But that goes into the decision about reproductive planning in terms of testing for men. So I don't know, Ephrat, is that similar to what's suggested in Israel, or?
Yeah, so the age of testing really depends on what's the purpose of the test. So if it's for reproductive planning, then you do it when you're planning reproduction, which might be earlier than 40. If it's just for prostate cancer screening, then you could probably wait till age 40 to do it. So it really depends on the context of the test. I would say in women, at least in our population studies, we really haven't seen practically any cancer before age 30. So I'm not sure we really need to start screening at 25, but it's funded from age 25 and on. But again, if you're planning to have children before you're 30, then you might want to do it even in your early 20s. It really depends on the context of the test.
Yeah, I mean, I think the lifetime risk estimates prior to age 30 are generally like in that less than 5% range, so it's low, but there. And then Alan, tell us something about Fanconi anemia and BRCA2.
Yeah, thinking about this in a screening manner. So some years ago, we identified a young child, a 2-year-old child who had a severe disease, an anemia and some birth abnormalities, and in the context of studying that child, we realized that this child had inherited 2 mutant copies of BRCA2, meaning not only was it sad that this child had such a terrible disease, but the mother and the father were both BRCA2 carriers. And when you do cascade testing, you actually find that both of those families, there's a number of BRCA2 carriers in that family. And you actually find that young child, one of the siblings was a BRCA2 carrier. So ironically, the identification of this child in a family that didn't realize that they were BRCA2 families, the identification of that child identified 2 families, with a large number of BRCA2 carriers. And actually in one case, and now we've identified a number of these children that are, and young adults even now, that have mutations in both BRCA2 copies. So the mother and the father are BRCA2 carriers. Unfortunately, in one situation, one of the fathers didn't know he was a BRCA2 carrier, and he developed pancreatic cancer. So in other words, identifying these families, preferably we would do across the board BRCA1 and BRCA2 testing, in the population. But instead, because we're not doing it across the population in the United States, you can find these these kindreds which carry BRCA2 mutations, and so
several,
that affects screening. So we're screening the parents of these children, right?
So several issues that you brought up there, which were also in some of the questions, which was, the state of pancreatic cancer screening, and this actually varies very widely across the world in terms of what's recommended. In the United States right now, it is a statement by the National Comprehensive Cancer Center Network to consider pancreatic cancer screening for all BRCA2 carriers starting at age 50 or 5 to 10 years younger than the earliest pancreatic cancer in the family, with either yearly endoscopic ultrasound or abdominal MRI. For BRCA1, excuse me, it's still recommended that only be done in the context of a family history of pancreatic cancer. But this is all evolving. The evidence base is limited. We try to screen everybody in the context of a study so we can answer more of these questions. So I think that's one thing. I wanted to just mention one other thing about Fanconi anemia, which is interesting, which is BRCA2 is part of a complex of genes. And Fanconi anemia is a condition which can be caused by mutations in a lot of those different genes. And so it's just kind of interesting to see, Alan, that kind of the similar condition can be caused by mutations in any of the genes in that pathway, or many, I should say. Yeah. No,
that's good. We'll talk about that tomorrow morning, but BRCA2 is a protein. It binds to BRCA1, it binds to PALB2, it binds to RAD51C, it binds to other proteins. These are all Fanconi proteins, but as you know, there's also some of those proteins are encoded by genes with variable penetrance and mutations with variable penetrance in breast and ovarian cancer. Yeah. So the connection is, I think about all these genes. When I saw Ephrat's lovely talk that she just gave, I see all these genes listed by their names: PALB2N, RAD51C, RAD51D. I think of them as Fanc A, Fanc B, Fanc C. To me, they're Fanconi genes. But,
yeah.
And I think that, but I think that they do converge on a common function. Right. Now, David Livingston, a few years ago, obviously a winner of the Global Award, showed, 20 years ago that BRCA1 had a very specific function. It was a with Ralph Scully, it has a DNA repair function, but then subsequently shown that all of these other proteins interact with BRCA1 and they turn out to be cancer susceptibility gene products as well. So
biology helps us figure out stuff in the clinic for sure. The question came up about pancreatic cancer risk, and again, we know that that's a risk more for BRCA2, lifetime risk in the 5 to 7% range, than BRCA1, lifetime risk in the 2 to 3% range, in the general population, 1 to 2%. But one of the questions was asked about what other cancer risks. So in general, we bundle breast, ovarian, prostate, pancreatic cancer into this bundle. Again, prostate cancer more for BRCA2 than BRCA1. Ephrat, what do you think about other cancer risks? Specifically, I was asked about uterine cancer and gastric cancer. So
I think there are conflicting results from different studies, and in my mind, when there are conflicting results, it means that the association is not 100% definite. So I would say it's one of those areas where I'll separate into my answer into two parts. From a research point of view, it'll be really important to continue to try and figure that out, and I think we need ever larger cohorts, and also there's a whole question of how they're ascertained, how we find them out. So that's one arm of it. And then the second arm is what do we do with it clinically in terms of our carrier patients. And there I think the most practical approach, at least that we've used, is to go by family history. So I think for things like gastric cancer or colon cancer where there are really conflicting results, I go by the family history. So if there's nobody in the family who's first of all, it's generally more of an issue for BRCA2 than for BRCA1 carriers. So BRCA2 are probably lower penetrance, is a lower penetrance gene, but paradoxically, there are more different types of tumors associated with it than BRCA1. But I will say if it's a BRCA2 family and there's nobody in the family who's had gastric cancer, I wouldn't recommend any gastric cancer screening. On the other hand, if there's a colon cancer family history and it's a BRCA2 family, I'll tell that person, well, you should have colon cancer screening, but it's really based on the family history, not so much on the mutation.
One of the other really interesting findings about the gastric cancer, stomach cancer risk is a study from Japan which really suggested that it matters, the background environmental factors matter. So in that situation, if you had H. pylori, which is an infection of the stomach, that is not uncommon, that if you had that and you had a BRCA mutation, your risk of stomach cancer was elevated. But if you did not have H. pylori, it really wasn't. So it really kind of goes to show that it's, and H. pylori testing is, if you, at Penn, if you have an endoscopic ultrasound for your pancreatic cancer screening, they actually just test you for H. pylori at the same time, just get it out of the way. There's also an easy breath test to do. So that's not a standard practice, but I will say that we kind of incorporated that it's easy enough to do. H. pylori is not very common in the, it's not as common in the US as it is in Asia. So there's obviously regional differences as well.
How about liver? I think about, BRCA mutations in China, where there's a lot of hepatoblastoma, and head and neck squamous cell cancers. I mean, is there any? Breast,
ovarian, prostate, pancreatic is, I kind of consider them the canonical tumors, and everything else is messy, is kind of how I view it. Gastric and BRCA2 is probably the next closest thing. And then there is a hint about BRCA1 and uterine, but again, the absolute risk goes from something like 2% to 2.5%. So the actionability of that information is challenging. So again, a lot more to do there. That does lead to sort of, there were a bunch of treatment questions. And so I'm going to start with, and again, this is the where are we now, with a basic treatment question, Alan, of how did basic science give us PARP inhibitors?
How do we give up, or how do we?
How did basic science lead us to PARP inhibitors? Because the story is pretty cool.
No, it certainly is. Well, actually, it is kind of complicated, though. Well, there's the principle you have to understand is synthetic lethality. It's an important principle in drug development. Essentially, if a lot of cancers, breast, ovarian cancer in particular, knock out a DNA repair mechanism. They knock out a mechanism. Like, why does a cancer knock out a DNA repair mechanism? You'd think that would be a vulnerability for the cancer. But if a cancer knocks out the ability to repair its DNA, that gives an advantage to the cancer, because now the cancer can undergo mutations. It can knock out p53. It can mutate other genes. It can break open its chromosomes. It could become more aggressive and more metastatic. So cancers knock out a DNA repair pathway is an advantage. But when they do it, it comes at a cost. Okay, it comes at a cost. Because now that cancer, because it's knocked out one mechanism, it has to upregulate another mechanism to kind of stabilize itself. And that's the PARP pathway. So if a cancer loses BRCA1 or BRCA2, now it's increased its reliance on PARP. That's the target. That's why the PARP inhibitor works, is because those cancer cells now are more dependent on PARP than all the other normal cells in your body, except maybe your blood cells, which is an issue. So I think that was elegant work by Alan Ashworth, former Global Prize winner, and Thomas Halliday some years ago, that this dependence became a target, okay? And that now we know that if we designed a drug against PARP, we would kill the BRCA1 and BRCA deficient tumors. And that principle of synthetic lethality is now coming into play in the development of new drugs. And we could talk about that.
Yep, that's in future directions. Yeah, we're going to get there.
We could talk about resistance.
Yeah, we're going to get there. But I think a thing to emphasize too is, this all came, the concept of synthetic lethality, if I have it right, started in basic yeast.
Yeah.
People like Drosophila and yeast,
exactly. These were not people thinking at the time, oh, I'm coming up with a drug for cancer. So the value of basic science, I think, particularly in this day and age, just sort of can't be overstated, which is you never really know where your next discovery is coming from. So just a couple clinical questions that I'll take care of. I was asked about duration and drug type, And just to be clear, how long you take a PARP inhibitor depends on and why you're taking it. So if you have an early stage high-risk breast cancer, the only drug approved in that setting is olaparib, and the duration is a year. If you take it for advanced breast cancer, there are 2 drugs approved, and you take it for as long as it works. In ovarian cancer, if you've been treated and you're taking it maintenance, generally it's 2 years, but there's a little squishiness around that, and there's several drugs approved in that space. And they do have different toxicities. I see Dr. Simpkins here who, for ovarian cancer, so niraparib gives more thrombocytopenia, and rucaparib, has a little bit more, the creatinine goes up a little, so we depending on it. But the most important thing is toxicity management, dose reduction as necessary. Don't be, I always say that when we develop drugs, we weirdly keep going up on the dose till we hit what we call maximum tolerated dose, and then we go down a level. And that is not the same as minimally effective dose, but it's actually hard for us to figure out that. And we always have a differential, so dose reduction is always important. So Alan, one other question: why do PARP inhibitors stop working?
Yeah, so same kind of reason that antibiotics stop working for a bacterial infection. I mean, growing organisms can evolve to become resistant to drugs. And actually, it's somewhat controversial. One possibility is the PARP inhibitor is actually causing mutations, which then allow the generation of resistance. Probably a more globally accepted possibility is if a person has a cancer, some of those cells will be sensitive to the PARP inhibitor, but some other clones of tumor cells might be resistant to the PARP inhibitor up front, right at the beginning. Okay, so this is called clonal heterogeneity. So if you get a PARP inhibitor, the tumor might regress in size because those PARP inhibitor sensitive tumor cells will die. But already in that tumor, there might be some tumor cells, a different clone, which is resistant up front. Okay, it's already somehow fixed its BRCA1 or BRCA2 mutation. It's somatically reverted in a will. So that's actually one of the reasons a lot of us in the field of drug development are saying PARP inhibitors alone might not be the curative tool, because that PARP inhibitor alone will kill some of the cancer cells, but there are these other cancer cells which are PARP inhibitor resistant. We need to give a combination with another drug that kills that other clone. So I think that that's why this idea of drug combinations might make more sense. Most of the tumor in a BRCA1 deficient setting will be sensitive to the PARP inhibitor, but there's already some tumor cells there that could be resistant up front, and you'd need another drug to wipe those out. Or you need the immune system. Whenever I see Bob Vanderhyde here, I think of the immune system.
Yeah.
The immune system might kick in and take care of those other clones. Okay.
Yeah, I think one of the hard things to know is that sometimes PARP inhibitors work great, and it's all we need. And so trying to figure out who needs more and whether we can predict the various resistance mechanisms, including reversion mutations, would be great. I mean, our colleague Kim Rice just published a study on pancreatic cancer in BRCA1 and 2, and although most of the time the PARP inhibitors stopped working, 16% of the patients in her cohort were out more than 4 years without evidence of disease, which is actually remarkable for pancreatic cancer. So we have to figure out why those people, it works so well, because that's not the usual. I have somebody who's been on a PARP inhibitor for 14 years. I keep telling him I think it's okay for him to come off, but I understand why he would like to stay on it. He does not, actually. So Mary Claire is pointing out, and there'll be a talk tomorrow about this, is that there probably are some mutations in BRCA1 and 2 that are hard to revert. They're hard to get the resistance around. Oh, that wasn't that? Okay. Well, I'll grab you later. It was. Nope. No, it had a standard BRCA2 Ashkenazi founder mutation. So we don't know why. And so someday we'll figure it out. Mm-hmm. So Ephrat, another question is, and this comes up a lot of times, I think some women are somewhat reluctant to come in for testing because they think we're going to tell them they have to have a mastectomy. So, is a mastectomy always necessary if you have a BRCA mutation?
I'll just say it's actually interesting because we just had a discussion at the national level about trying to define quality factors in terms of delivery of care for carriers. So for example, a quality measure would be, are women having their annual MRIs? And somebody said, well, we should have as a quality measure performance of risk reduction salpingo oophorectomy. And I said, you can't have surgery as a quality measure because the person has to decide if they want to have a surgery or not. You can't say, you're not going to force people to have surgery. So the thing about risk reduction mastectomy is, does it offer better protection? Absolutely yes. I mean, I think it can't be ignored. Is it difficult for some women to make that decision? Absolutely, it's a difficult decision. So I think the important conversation to have is to say, what is your risk if you do or do not have a mastectomy? And I think that as opposed to oophorectomy, where the delta between the difference in outcome between having the surgery or not is life or death, that's not necessarily true for risk reduction mastectomy. So it definitely reduces your risk. But in terms of mortality, the difference is not that huge because we have excellent early detection and we have excellent treatment. So I think that's a nuanced discussion to have with the
and it's different for BRCA1 versus 2. I mean,
absolutely.
I think the mortality benefit has been difficult to see for BRCA2. I'm not saying it's not there for any individual patient, right? It's different. But I think, and it's over a lifetime. So when you talk to a 25-year-old, even these benefits are, till age 80 kind of thing.
And I also want to, I think an important point to make is it's not a one-time discussion.
Exactly, yeah.
What we often see is that women who've had a number of scares, so they start having surveillance, and then there's something found on the MRI, and they have a biopsy, and they have to wait for the biopsy result. This happens once or twice. They say, okay, I've figured this out. We actually had a couple where the male partner came to us and said, you have to convince my wife to have her breast removed. And I said, why? He said, I can't stand that once a year, we should, every 6 months when she has her breast imaging, I die, and until I know she's fine.
You're like, not your decision, but okay, noted.
No, that's okay. So you should discuss it with her, but it was touching.
Yes, but I do think that as you alluded to, women are making all sorts of decisions, finding their partners, whether they wish to breastfeed, sexuality, quality of life, body image, these things we acknowledge are very important as part of the decision making. That it has to be specifically stated, but avoidance of developing a breast cancer, avoidance of needing therapy for breast cancer, and so this balance.
I think that's important to say because I was just talking about mortality, and it doesn't make much of a difference between mortality, but having breast cancer detected and then having to be treated is not the same as not having it in the first place. So it's different apples and oranges.
So these are all, very nuanced conversations. And, another issue that came up, well, what about chemo prevention? We're going to talk about sort of the future in 1 second, but there are medications out there. There's tamoxifen, raloxifene. These decrease risk of breast cancer. They're not well studied in BRCA carriers, but they exist. There's Duave, which weirdly was not available in the US for a while, but is back available again, and that's a combination selective estrogen receptor modulator with estrogen, and there's some very preliminary evidence that could be that could lead to risk reduction. We don't have a lot of uptake in the US, and I'm just curious if there's a lot of chemo prevention use in Israel.
No, there's actually very little. It's also true for the general population, right? Because supposedly, if you look at the studies, then every woman age 65 or older per risk should be receiving tamoxifen or raloxifene, and that's not the case either.
Right. So
partly it's the side effects, but I think there are other probably factors.
I think it's sometimes people are having their children, and then once they have their children, they often then have their oophorectomy, and then they're interested in hormone replacement therapy. But that's why Duave is a really interesting potential drug because it helps with menopausal side effects. And so I think we need to do a lot more research, which brings us, I know I didn't get to all the questions.
I could comment on this ongoing discussion if you want.
Sure.
So there are new drugs that are.
Well, that's the next section.
That's your next question.
That's where we going.
That's where we're going.
So
okay.
that's why right at
Frame
5:30 we're
frame the
making our
question and I'll do my
transition.
best.
So there you go. So take it from there. Where are we going next?
Well, I mean, there are drugs in development. Just as PARP inhibitors first came in active use in the treatment of advanced BRCA1 and BRCA2 deficient tumors. Now there's new drugs, a drug called a Pol theta inhibitor, Pol-Q inhibitor, or a USP1 inhibitor. These drugs could also kill BRCA1 and BRCA2 deficient tumors. But to develop those drugs, initially, the clinical trials are being deployed are using those drugs in the setting with advanced disease. Advanced disease. So a PARP inhibitor for advanced disease, then it dialed down to maybe to the setting where it could be used preventatively. A Pol theta inhibitor or a USP1 inhibitor, there are clinical trials. Those trials are being performed on patients who have very advanced disease that has failed PARP inhibitor or failed platinum or some cytotoxic drugs. But if those drugs move forward and have an effect, then the hope is you could dial those drugs down and perhaps use those drugs in combination with a PARP inhibitor, or better still, dial the dose down and perhaps eventually those drugs could be used as a preventative drug. Yeah. So I think, but unfortunately, it takes a while to prove that these drugs are working, and the proof will come from clinical trials with patients with advanced disease.
I think it's well said that when we do drug development, we generally start in the advanced setting, and we do phase 1 for safety. And in general, then you have to win in metastatic disease, and then you have to win in early stage cancer before you ever even think about prevention or interception, which may be, by the way, completely the wrong strategy, but it's just, that is the pharmaceutical company strategy, right? So we are, Judy Garber and I, Judy works at Dana-Farber with Alan, have been working for a while with one of the drug companies to even just start we're almost there, a PARP inhibitor study to give just a month of a PARP inhibitor prior to risk-reducing mastectomy, just to even say, will women find this acceptable? Can we get the dose right? Can we start to look at biomarkers? And because you're not going to give that drug continuously. When I'm going to throw out the term cancer interception, which is different than prevention, if you will. Prevention, if you will, you don't smoke, so you don't start the changes that are bad. Interception is things are kind of starting and you're going to intervene at the earliest places you can. And you can think about this in a little bit of like, you're starting to grow the weeds in the garden and you periodically weed them and get you back to baseline again. And then you can do that intermittently. And so the question is, you probably don't have to take a PARP inhibitor forever, but if you could take it, again, theoretically, you'd take it for a month and wipe out all those, bad cells and then do it intermittently. But again, there's many, many researchers from around the world looking at mouse modeling and other work. And again, these other drugs, Alan, that you mentioned, where will they sit in? There's been other attempts to use other drugs like denosumab, which is a bone strengthener. And we have to learn from that because that clinical trial did not enroll very well. And so we have to think to ourselves, why was that and how can we do better? We do have a vaccine study that we did enroll well onto, and somebody asked me for the update there. It was safe. We vaccinated 44 BRCA carriers, including 28 people who had never had cancer. Half of them were men, so men are interested too. They get cancers, they are interested. We were using a DNA plasmid-based vaccine, which is given with something called electroporation. So we're looking at those immune endpoints, and we're also thinking about ways we could use RNA and different kinds of vaccine development strategies. So we have an immune interception institute here at Penn where we're really trying to dig deep into this space and figure out what we can target, how we can target it. But we do know that BRCA carriers could be the people, to target in this space. Yeah. But first, we have to find BRCA mutation carriers. So, Dr. Ephrat, you guys have done such an amazing job in Israel. Tell us about how you've managed to do population screening in Israel.
Yeah. I think a big element is the background. So we have a socialized health system. So people are used to sort of, I would say, organized programs run by the state that have to do with health. So I think there's there's a readiness of the population for this type of program. And as I mentioned in my talk, for example, we have a very well-developed preconception screening program. So people that are planning to have children get screened for genetic mutations to see if they're both carriers and they might be at risk for a recessive disease. So that's been going on for decades and decades. So I think there's already a mindset of the general population being aware and willing to do genetic testing. So I think that's an important element.
And just a quick comment on that. Years ago, when we first started the Vassar Center, we did these focus groups in various synagogues, and everybody knew about Tay-Sachs, and like nobody knew about BRCA. I think that is changing, but I do think that reflects the fact that there was already this awareness.
I think the baseline awareness plays a large role. And then, I think cancer genetics clinics were set up in the late 90s, early 2000s, and they became more and more acceptable. But it's been a very long process. I think when we talk about the population screening now, it seems like, oh, this is so obvious. How come this didn't happen 20 years ago? But some processes just take time in terms of, I would say, both the population becoming used to the idea and the medical establishment. When I was one of the first cancer genetics clinics in Israel, it was 1996, and physicians told me that this was a terrible idea. In Hebrew, there's an expression to put a healthy head in a sick bed. Right? I mean, you're a healthy person. Why would you start, getting yourself tested for cancer risk? Why would you want to know that? Why would you want to do it? And today, that seems to us, very simplistic, or even worse. So I think, I guess some steps just can't be skipped. You sort of have to go through the process. But I think what it taught me is that it's very health system dependent. So I think it's very easy to say, oh, we're doing population screening, it should be done everywhere. But you really have to tailor it to the way your own system works. And there are health systems in the States, like I think Geisinger or Kaiser, whatever, that can probably do this more easily than other systems.
Yeah, I think that there's a lot going on in this space, and there's the component of making sure everybody with certain conditions like ovarian cancer, pancreatic cancer, every one of those people should get tested. Let's make sure of that. Let's get the lowest hanging fruit, these people with strong family histories, and then simultaneously, and Kate Nathanson, just got a big grant to start really actively looking at how to implement population screening. But I think it's a consortium, and I think their first task is to pick the gene list. So this is not such a minor thing, which is, okay, which genes are you going to test for? And we had some really interesting conversations today about how we're also very cancer focused, but there's other genes that matter too. And so how do you, think about this across the board? It is, if you will, useful that 1 in 40 people have one of 3 specific mutations, which in the early days made it also, now it's cheap to do genetic testing, but in those days, the cost was a major barrier.
Right, it was about $3,000. To get BRCA testing.
Yeah, so
But
you are our example. So.
No, but I think it's also a mindset difference, I would say, between Europeans in general. I'm going to hazard and call Israel a European country, and the United States. The screening mindset is not 100% mindset. I think the American mindset is more 100%. We have to get every single mutation.
You're missing out, baby, definitely.
And if you're not reporting some obscure VUS that might one day prove to be actually likely pathogenic, then you shouldn't be doing the whole thing. And the screening mindset is different. It's getting the most people you can for the maximal benefit. It's trying to find this, I would say, point of optimum where you're identifying enough people with enough risk, and you're not spending your resources on things that are much rarer and less likely. But I think that's it's a big cultural difference.
We have a lot of philosophical debates these days for genetics. That's for sure. I mean, there's a lot of debates about how we should be doing this. I wanted to get back to a little bit of the interception question, because we were specifically asked about the new pancreatic cancer drug, daraxonrasib. And yes, I have practiced saying that, daraxonrasib. For those of you who don't know, daraxonrasib is not BRCA specific. It's a KRAS inhibitor, but has actually been very exciting to see in advanced cancer patients, and actually work by Bob Vanderheid-Minthan, who's speaking tomorrow, and Ben Stanger, published in Science, showing that you could use RAS inhibitors to actually prevent pancreatic cancer in mice. And so really kind of interesting also idea about the future of interception. But Alan, I'm going to ask you a basic science question. It took a while to develop KRAS inhibitors. They were considered undruggable. And so, can you just comment on just from a basic science perspective, how people get from it's not possible to, hey, we can try to figure it out?
Yeah, we're going to try to figure it out. Yeah, some bold chemists step forward. Well, one thing that is relevant to this discussion is this is a RAS inhibitor. So there are pancreatic cancers that have RAS mutations, and there are pancreatic cancers that have BRCA2 mutations. And there are pancreatic cancers that have both, a RAS mutation and a BRCA2 mutation. So the question is, should you just simply use the RAS inhibitor, which is a degrader, and a PARP inhibitor?
Yes.
And there shouldn't be any conflict of using those two drugs. I believe they're both oral drugs, and they both. There's no scientific reason to think that they'd be competing in some way. Sometimes when you give two drugs, one's competing with the other. I don't think in this setting that would be the case. I may be wrong. You talked about an elegant story today, Susan, where BRCA1 situation where if a tumor is a BRCA1 mutation, PARP inhibitor, but if there's also ER positive, estrogen receptor positive, you'd give a CDK4/6 inhibitor, but there actually might be a conflict, which you described beautifully, in using those two drugs in one setting. So that doesn't answer your question, but people in the field, we just got back from the American Association of Cancer Research meeting, very exciting talks about RAS inhibitors. Okay, so RAS is a protein which is hyperactive in a proliferative pathway, in a cell, in a signaling pathway which makes cells grow quickly. And if you could inhibit or get rid of that RAS protein, you're going to slow down the cell's growth, and you might kill the cell, might kill cells. The problem with RAS is it was just the structure of that protein just didn't lend itself to a simple lock and key. It was a protein. We like proteins that have a nice open hole, and you design a drug and you insert it, and you insert the key and you kill the protein. The RAS protein was undruggable. Okay, it was really difficult to inhibit it in any way. So this group and a few groups at the same time came up with a drug which binds to the RAS protein and glues onto it. It's called gluers, and then brings in another protein, and then essentially by gluing these proteins together, it's inactivated the RAS protein, and it's working. I mean, it really is working in an exciting way. So now we have a drug for an undruggable target, and I think that the success, it's an amazing success, largely chemistry driven. But looking for a RAS inhibitor, that's, as long as I've been doing molecular biology, that's been a major goal.
I know, it sounds so minor because it's like, oh, now we drugged the undruggable target, but it really was like, no, there's no way to do this, to, okay, yeah, we can. Which then, okay, let's lead, everyone wants to know about AI and how AI is going to help us. Ephrat, how is AI going to help with your work and accelerate progress?
Well, I think there are obvious answers in the sense that things like virtual genetic counselors, chatbots, things like that will offer people who are interested more information in a more palatable way. And it's a two-way street. It's both providing information on risk and options, et cetera, and both gathering information, let's say on family history. Also, you can envision the kind of, we were talking about nuanced conversations about important decision points like risk reduction mastectomy or risk reduction oophorectomy. You can see how AI agents could be helpful in that respect. But that means we're going to have less human interface. That's a good question. How much will people go for that? Although it seems from what I read about AI is that, there are now people get psychological therapy from AI agents. So maybe genetic counseling is even simpler in that respect.
I still think I'm useful, but I don't know for how long. But
I think
but people can access. I think one of the things that I think of is that right now it's hard to access medical care, and so we should figure out how to use this so that more people can access information in a way that's understandable. In our clinic, the main way I'm using AI right now is that it's an incredible search tool. There's many, there's I won't shout out one specific one, but it's very easy to search for information, but it's imperfect, just like all searches are, and you do still have to know what you're doing. So I don't think it doesn't replace the synthesis of information yet, I don't think. We're using ambient listening, in some clinics to sort of write people's notes and decrease administrative workloads. So there's things like that. But I think that there's a lot of interest, right, in AI for drug discovery. So, Alan, do you want to, comment on that, how that might work?
Yeah. No, it's been amazing. So my lab is focused really on finding drug targets. I'm good at finding targets. We found USP1, we found Pol theta, we found these protein targets, but it would take me a long time to design a drug myself that hit these targets. Now with AI, you can take the protein, a linear stretch of protein, and use this program called AlphaFold, and it can tell me how this protein folds up into a three-dimensional structure. So that's one use of AI.
Was a Nobel Prize winning.
Nobel Prize, right?
So,
2 years ago.
Yep.
Not by an academic group, by a Google.
It
was a combination. That's an interesting part in of itself. But now that we know how the protein folds, now we can use AI to design the drug to hit the target. So 2 steps in drug development have taken over by AI: how the protein folds and how to design the target, how to design the drug to hit the target. Very humbling. So you've got to tell me, Susan, how is AI going to change clinical trials?
Yeah, this is, and that's what I was going to say. That's the challenge we've had for a long time, which is things look so good in vitro systems. They look so good in mice, and then we take them to people, and they don't look good.
Right.
And there's a lot of complexity to that: clinical trial design, patient selection. You have to be so careful when you design a clinical trial, and it can be very frustrating for patients because they want to be on a clinical trial and it has these very specific criteria. And why does it have to be those specific criteria? It's because if you don't get it right, your drug can not work in the clinical trial, and then the drug's done. And unfortunately, I'm not saying it should be like this, but drugs don't get many shots on goal. If they go forward and they've picked the wrong patient population to test the drug in and it doesn't work, you only get so many tries at that because it's extraordinarily expensive. So I think that's the question is, can AI help us better pick the right patients for clinical trials by kind of looking at all the data that's out there? But patients aren't machines, and that's been long our problem, is that it's very unpredictable. And so most drugs that enter phase 1 trials do not succeed. But again, is that because there was something with the science, or was there something with the trial design? I'm not sure. I think there are some other interesting things about using AI. Clinical trials are very expensive in part because of how the data is collected and entered into databases. And now, AI is going to, I think, really help with that and basically pull data in a way that it's not a human sitting there entering data, which then, since they can make mistakes, then that gets audited, then there's corrections. So I do think that there is going to be hopefully costs will come down as some of those things are taken over. So I don't have a great answer for you, except that, yes, I hope that we can get more drugs all the way to the finish line, which is like it got identified and it's actually successful and speeds up the process, because it does take some time to get drugs. One of the other questions was gene editing approaches. So, I mean, so we've talked already about pre-implantation genetic testing. That's not gene editing. We don't edit embryos, but we select embryos. So that's an approach. In terms of gene editing, there's been just some really incredible things that have happened in the last year. Karen Mercenuru here at Penn was involved in a study with CHOP, where a critically ill baby, they did sequencing, they figured out the problem, they developed a mRNA, injected it, fixed the liver, baby's better, right? Which is incredible, right? For metabolic diseases. There has been a study by Regeneron about congenital deafness, not a high percentage of kids with congenital deafness, but they can cure that particular form of congenital deafness. So it's really amazing. But so then the question is, could you apply it to BRCA1 or 2? So we have recruited Kieran even before this incredible result with baby KJ. I want to say I approached him before he did that. And so he's starting to work on this. One of the issues is just the delivery, right? Because
tissues.
How do you get it into the right tissues? So for the ear, for these kids, they can just inject it into their inner ear. For things that are dealt with in the liver, you can inject it; it goes to the liver. But could you put it in a gel and a fallopian tube? We don't know. We're trying to start to be creative, about this. But the gene editing technology has just changed so much, because they can actually almost do a word processor. They can actually correct things as opposed to just take things out or put things in, which is a major difference. So I don't know if either of you have comments, but as a medical geneticist, you must be looking at this thinking, this is very cool.
Yeah, it's very cool. B, I think it's really it's going to be the issue of delivery. So far, if you look at the examples where it's been successful, so it's either injectable in the ear or anything to do with the blood. In hematology, it's been a whole revolution, because the blood system is easily reached, and with the liver, it's the lipid nanoparticles.
Right.
I think breast and ovary are more challenging, but it's likely.
Hey, we had an undruggable target.
I was going to say it's likely to happen. And actually, what gene editing says is if it's in the DNA, it's druggable, right? Because it means that if it's a DNA variant, you can correct it with editing, and that. So, the principle is already there, but you just have to find the right delivery system, basically.
So very very cool next steps. Again, do we know it'll work? We don't know, but again, lots of different shots on goal. So the goal is just to try as many things as we can to make things better. So one other thing I just said, it was asked, I'm sorry to skip back to AI. One of the questions was, can AI help with more personalized risk assessment? And this kind of comes from work done in large part, started really at Mass General, looking at mammograms and whether or not you can use AI to look at risk related just to what's in the mammogram. So not so much early detection, but if AI can look at your mammogram and say, are you at risk at cancer for, say, the next 5 years? And it actually can, and it's pretty cool. But those are mammograms, and that's in the general population. So obviously, we hope to be able to kind of apply that to MRIs or mammograms in mutation carriers to kind of say, we can give you a little bit more of a sense of your 5-year risk. And it's also potentially modifiable, meaning you're going along and you're okay, and then your mammogram looks different and now your risk is higher. So that could be really interesting. So we're not there yet. That's another really interesting area.
But I think what's important about it is we're so used to talking about lifetime risks.
Right.
And actually, we might want to start looking at these closer windows of time, which are more relevant, perhaps, and it's probably going to be more accurate also than projections up to 40 years from now.
Yeah, we're really bad at validating lifetime risk for all the reasons that you might think. So, in fact, some of the guidelines, not in BRCA carriers, but in these lifetime risks of 20 or 25%, they're starting to say, let's look more at the 5 and 10-year risk estimates to decide what to do, which makes sense.
Right. It's changing pathology too. AI is changing pathology.
It's a good point.
If a person has a tumor, you get a a biopsy, you make a slide, a thin slide of that tumor and look at the cells. A pathologist, will study that slide and say the different kinds of cells on the slide might, say, okay, this is a certain kind of cancer. Now with AI, you can actually study that slide and actually make some predictions as to what are specific characteristics of that. Are there lymphocytes there? Is that tumor more likely to respond to immune therapy than another tumor? So it's changing AI. AI is changing pathology.
I think radiology and pathology are really the
Huge.
ones that are coming in most quickly, and then how to just take vast reams of information and make a story out of it. So a lot to come. I mean, I think we'll all have jobs, or the robot overlords will take over. It's one of two scenarios. I'm not sure. But with that in mind, I just want one last thing. What do you hope for in terms of the next great breakthroughs in the next 5 or 10 years that are going to help, our patients? So I don't know who wants to take that first.
Go ahead, Ephrat. You go.
I mean, I can say what my dream is. I don't know, how it'll come about. But I think, for me, one of the most frustrating aspects is the fact that, it's been 30 years since the discovery of BRCA1, BRCA2, and we're still offering surgeries. And there's got to be some better way of substantially reducing risk that's not surgical. And in that sense, maybe the gene editing approaches or the interception approaches might end up working. But to me, that's sort of the greatest frustration, in the sense that I feel that we've done a lot in terms of identifying more carriers, but in terms of what we're offering them, it really hasn't changed much in the last 30 years.
Yep, I agree. Alan?
Prevention. We talked about prevention a few minutes ago. I think that would be, I love targeted therapy. I think we've moved away from more cytotoxic, intravenous therapy to more oral targeted therapies, given in combination. That's better. And if that will improve, and if some of those drugs could be used for interception or prevention, that would be fantastic.
Our fervent hope is that our conversations, as you said, become different.
Yeah.
And I think we all, we see a lot of 25-year-old women, and we want to have a fundamentally different conversation with them, and we are working on it. So I want to thank you all for your time and attention, and just let us know if you have additional questions. Thank you very much.